My name's Tom Powles. We're here today with GU Oncology Now at the Euromigos meeting in Nashville, Tennessee 2023. I'm here joined by Shilpa, Sia and Petros. Petros, do you want to introduce yourself first, then we'll come around this way and then we'll kick off?
Tom, it's so fantastic to be here. I'm Petros Grivas. I'm a medical oncologist in Seattle, in Washington, United States. I'm a professor and also the clinical director of the GU Cancers Program at the University of Washington and Fred Hutchinson Cancer Center. Thanks for inviting us here.
Thank you. Pleasure being here. I'm Sia Daneshmand. I'm Director of Urologic Oncology at USC Norris Comprehensive Cancer Center in Los Angeles, California. I'm also Director of the Clinical Research there. Thank you for having us.
I'm Shilpa Gupta. I'm a Director of the GU Oncology Program at Cleveland Clinic in Cleveland, Ohio, and really honored to be here, Tom.
We've all got great titles, haven't we?
Long titles.
Yeah, amazing. So today we're going to talk about some of the changes in urothelial cancer. We're going to talk initially about advanced disease, and we're going to talk about first-line metastatic. We're also then going to dive in and talk a little bit about erdafitinib and ADC doublets. And then we're also going to discuss a little bit some of the changes we're seeing in non-muscle invasive bladder cancer, which is, I think it's super exciting.
Yeah.
And we'll do it in that order. We'll talk about some toxicity issues too, of course. Who wants to kick off with what happened at ESMO? Shilpa, would you like to start? Would that be fair?
Yes, of course. It was my first ESMO in person, and I thought it was the best ESMO ever. The frontline bladder cancer presentations and the standing ovation that you got for the EV-302 was really mind-blowing. I think for the first time we've seen in 3 decades that something beat platinums, and it was really great to see that, as well as the CheckMate 901 of nivolumab gemcitabine. And then we also, for the first time, have seen some data on sequencing strategies in metastatic disease, with the TOR trial being negative and really perplexing as to why erdafitinib did not do as well as pembrolizumab in FGFR-selected patients. And I thought the entire breadth of the data presented was really great.
Shilpa, you were on that 302 piece. We're going to talk about that in a second, but maybe, Petros, we could start with you, because Michael van der Heijden did an amazing job when he described the data looking at cisplatin-based chemotherapy with nivolumab and maintenance nivolumab versus first-line standard GemCis, GemCarbo chemotherapy. That trial was a positive study. In the past, we know that there have been studies which have had marginal results. The chemotherapy atezolizumab study had a positive PFS. It actually, its p-value was 0.05 and just missed OS by a tiny amount. And then there was the 361 study, which didn't show PFS or OS, but actually the numbers were in the 0.7s and 0.8s. And with hindsight, I was kind of involved. The statistical analysis plan probably wasn't perfect, but I can say that now. I think I've got over the counselling's helped. So, Petros, talk to me about the results of that study. What did it show? Did it surprise you? And I guess the key question, and Shilpa, this is really important for you too, and Sia, you might want to dive in. Is it better than maintenance of avelumab? And should we be giving chemotherapy and immune therapy together?
Great questions, Tom, as always. So let's start by the historical context. As you mentioned, IMvigor130, chemoatezo versus chemotherapy, and also KEYNOTE-361, which was chemo-pembro versus chemotherapy. Those trials did not change practice. There was no substantial difference in overall survival. As you mentioned, the IMvigor130 had a very marginal, modest PFS benefit, but did not change practice. So in our mind, the chemo plus concurrent checkpoint inhibition combination did not have enough value, and we definitely had the very significant and impressive OS benefit with avelumab maintenance in the switch maintenance setting in the front line with the Javelin Bladder 100 trial. So we all thought that the sequential approach is the way to go, not the concurrent approach. Now, I think one caveat or thing to keep in mind is that IMvigor130 and KEYNOTE-361 lump together cisplatin and carboplatin. And this may have potentially impacted the performance of the control group there. And also, if you think about, there may be some differences in the immunomodulatory effects from cisplatin versus carboplatin in the tumor microenvironment. Maybe cisplatin may be a better partner for immunotherapy. So that may be a hypothesis why the GEMCIS-NIVO versus GEMCIS was a positive trial. If you look at the response rate, specifically as that endpoint, you saw that the GEMCIS-NIVO was in the mid-50s, right, in response rate, and the GEMCIS was about 43%, slightly lower compared to what we saw in the performance of the control group in the other studies, but in the ballpark, in the 40s area, slightly numerically lower. But still, I think that the GEMCIS performed really well because median OS was about 16 months in the control group. So I think that this NIVO really prolongs overall survival. It's a positive trial. And the big question is it was a trial because of the concurrent administration of IO, the maintenance component, or both? It's extremely hard to tease this out. Yeah. If you look at the curve separates relatively early and then stays separated. It's very hard to compare between the CheckMate 901 and the Javelin Bladder 100 trial because of different designs. If you look at the reasons to use GEMCIS-NIVO upfront will be the clinical complete response rate was about 22%, and the median duration of response was 37 months, almost 3 years. And the primary progression rate, at least in the first scan, was less than 10% with GEMCIS-NIVO. Obviously, many patients may have progression later on. Bottom line is, it's hard to argue to compare between the GEMCIS-NIVO and the maintenance avelumab strategy. I would say it's probably attractive based on the primary progression rate, at least, and the durable clinical responses, that you may potentially keep more patients on treatment if you add the NIVO upfront. So in the absence of direct comparison and absence of a direct answer to your question, I think GEMCIS-NIVO is a very reasonable approach in cisplatin-eligible patients in countries where pembro-EV is not available, not reimbursed.
How much of the 0.78 overall survival hazard ratio, how much of that is being generated by the maintenance period? Because avelumab has a hazard ratio of 0.69. It's only maybe half the patients who get it, maybe fewer. But if that's a sort of a 30% or a benefit, 30% benefit for half the patients, that would generate a hazard ratio of 0.15, 0.85 would be maintenance therapy if that were true, and here we're 0.78. So is the survival being driven by the concurrent piece, or is it just those responders? And if it is the responders, who are those responders?
Extremely good questions and impossible to answer this. So the question is...
I'm going to answer impossible questions. My only goal is to ask impossible questions.
But very important one. So the question is, does the concurrent nivolumab during the chemotherapy administration adds value, it contributes to the survival benefit noted in the CheckMate 901 trial? As you mentioned, Tom, the hazard ratio 0.78 is not that impressive, I would argue, but it made it, right? It made statistical significance. Again, if you look at the timing when the curves separate, it's probably starting, probably during chemo, maybe at the end of the chemo.
Do you think that's right?
I think it's probably...
I think they separate.
Yeah, that's what I also thought.
At the end, after the end of the chemo, right?
Almost in the maintenance period.
Yeah. So the question is that driven by the maintenance component? It's possibly the case. It's very hard to tease this out. And I would argue that if you think about the maintenance avelumab, you save cost and toxicity with the concurrent administration of avelumab in the chemotherapy induction phase.
Yeah.
But the question is, we'll never find the answer. And the question is, again, which is not clear, how many patients you do not lose with progression if you don't use the IO upfront? Yeah. But we don't have the right answer.
I'm coming to that. So, Sia, Shilpa, so the question I guess patients are going to ask is, if I don't get the nivolumab now, there's a chance that I'm never going to get immune therapy, because if, heaven forbid, my cancer progresses and things are going wrong, it's all growing too fast and we lose control. Do you say to patients, actually, you're probably right, let's give them nivolumab now? Or do you say to them, the data doesn't support that, and therefore you don't need it now, and the two probably don't work that well together? How do you take this data to your patients?
That's a great question, Tom. I think we have to put it in the context of the CheckMate 901. Hardly anybody got maintenance immunotherapy in the control arm.
Yep.
So we are comparing it to the historical just chemo arm.
Actually, 20% of patients on the chemotherapy control arm of CheckMate 901 got avelumab. So suboptimal, but it was about 20%.
Right.
But it's less than you'd expect.
Yeah. Less than what you would expect, right? Exactly. So, and then I think to tell the patient that you absolutely need nivolumab right now, otherwise, you're in for really bad news, won't be accurate. I think we have to discuss the data, and in my opinion, the curves did separate after the chemo period, And, are we going to lose some patients who may progress up front? So obviously, if you're seeing a patient with a lot of bulky disease, visceral mets, you want to offer them nivolumab up front. But I don't think every patient needs to be offered.
Sia, what's your take on this from a urology perspective? You must be looking and wondering what on earth they're getting. Why are they obsessing with these numbers? They all look the same.
We just want to take out the bladders. No, let me just bring up GU257, Matt Galsky's phase 2 trial, Gemcis Nivo, given in the neoadjuvant setting, right? We're seeing the same sort of benefit. It's a phase 2, everyone is getting Gemcis Nivo, with the primary objective being the patients keeping their bladders, the complete response rate.
Yes.
And we have a good number, at more than 50% of the patients able to keep their bladders. We haven't seen this kind of complete response rate with chemo alone, right? The typical CR rates are 22%, something like that, based on cystectomy. These are patients who got to keep their bladders. I have number of these patients in my practice right now who are several years out and are disease-free. And we thought, well, maybe the DDR mutation patients are the ones who are responding well, and it hasn't really panned out. We're not quite sure, who the selection of which of the patients. So I kind of believe this data. I think, like Shilpa said, the more volume disease you have, the more sort of visceral mets, and you think this patient, if they don't respond to Gemcis, perhaps it's best to put that on initially and get the IO checkpoint inhibitor along with the chemo from the start.
See, I'm going to ask questions kind of miles off piece, and I apologise. So what is PathCR as an endpoint in urothelial cancer to these neoadjuvant therapies, and what do we have to do to improve on it?
Yeah, great question. I think it's a double-edged sword. PathCR right now, well, the gold standard is a cystectomy, right? And a pelvic lymph node dissection showing a complete response, but both in the bladder and in the lymph nodes. We and others have shown that it's not just the bladder. 5 to 10% of patients who have CR in the bladder actually have positive lymph nodes. So they're YPT0 and plus, and we published this. So you have to look there as well. These are the patients who are later going to fail. Well, currently, if you're going to keep the bladder, what can we do to determine a true CR? It's not a PathCR, but so we have to do the best sort of enhanced cystoscopy that we have. Currently, we use blue light if you have it. We have to do random directed biopsies, I suppose, because you'll miss CIS and carcinoma in situ and some invasive disease. Sometimes the bladder doesn't look normal after neoadjuvant therapies. It's not like we look in there and say, okay, there's no disease. And we need better imaging. Unfortunately, MRI and CT and PET and all the current modern imaging really hasn't been great in showing us, there's always some thickening, there's some, abnormality that we just have to look. So I would say proper staging in the operating room with biopsies, TURBT, to really ascertain, and cytology, just make sure you have no disease. The lymph nodes you can't do anything about. 3 millimeter lymph node positive disease, you're just not going to pick up, unfortunately.
So we've talked about the neoadjuvant nivolumab cisplatin. We talked about some grayness about whether cisplatin was better as a dance partner than carboplatin. I'm not sure we've answered that. Sia, you've said actually in the neoadjuvant setting that might be the case. I've got some doubts in my mind, as you know.